So to introduce our keynote speaker, I'd like to introduce Dr. Andrea Calcagno. He is a recovered healthcare worker who recovered from COVID-19 when he was working as a frontline worker as an infectious disease and HIV doctor in Italy during the brunt and height of their epidemic. He is an assistant professor at the University of Torino, Department of Medical Sciences, Infectious Disease Division. Dr. Calcagno is an HIV doctor and a member of several panels and committees, including the Italian guidelines on the use of antiretrovirals and the management of patients living with HIV, the Italian cohort of HIV-positive patients, and the Italian cohort of HIV-positive geriatrics patients, and the Italian registry of non-tubercular mycobacteria. Dr. Michael Ryan will now talk about the emergency response to the pandemic at the level of the World Health Organization. Dr. Ryan is the executive director of the WHO Health Emergencies Program and has been at the forefront of managing acute risks to global health for nearly 25 years. Dr. Ryan first joined the WHO in 1996 with the newly established unit on emergency preparedness and responses, and has been in leadership roles at the WHO ever since, leading many responses to high-impact epidemics. Next, Professor Laurent Nelson will talk about the disproportionate impact of the COVID-19 pandemic here in the United States on racial and ethnic minorities. He is the Associate Dean for Global Health and Equity and Associate Professor in the Yale School of Nursing. Professor Nelson's research involves studying the implementation and effectiveness of interventions to address anti-Black racism and sexual stigma at the organizational level, and treating their traumatic effects that clinically manifest at the individual level. Next, Ms. Reem Musa will talk to us about migration and displacement in the face of the COVID-19 pandemic worldwide. Ms. Musa is a humanitarian advisor on forced migration at Médecins Sans Frontières, or Doctors Without Borders, focusing on the humanitarian aspect of displacement, asylum, and migration policies. She is currently serving as the Humanitarian Affairs and Advocacy Coordinator in the organization's COVID-19 Emergency Task Force in Brussels. And finally, Dr. Quat Thi Hai Quan is the ED of the Center for Supporting Community Initiatives in Vietnam, and will talk about the community response to COVID-19. Dr. Quat graduated from Hanoi Medical University and has a master's degree in sexual and reproductive health from the London School of Tropical Medicine and Hygiene. She co-founded the Center for Support Community Development Initiatives in Vietnam, where she currently covers the role of executive director. She's also a member of the Strategic and Technical Advisory Committee on HIV and viral hepatitis for the WHO. Thank you, Dr.
Good morning, everybody. It's a real pleasure to share with you my personal experience on COVID-19. Well, from my point of view, as one of a healthcare worker. It's a bit strange to present something that is not data or research, so it's more on a personal basis, so it's my first time. Well, I'll start with the disclosure slide. I have no conflict of interest, and I just put two scientific slides in my whole presentation. So the first one is this, in order to give you an idea of what happened in northwest Italy. Piedmont is where I work. Turin is the largest city. You see here the epidemics last week counted 31,000 cases, and the first one was diagnosed on February 21st, although the first symptoms appear at the beginning of February. This is the same graph, but telling you how was my COVID-19 actually. So at the beginning of February, it was starting hard. So every one of us was trying to get most data we could from China mostly, and trying to see how was the diagnosis, how could treat our patient, and trying to understand it as much as possible. Then at the end of February, it started chaos. So we started having hundreds of patients, and we had just to get them in to create new COVID-19 words. And so really chaos. We worked a lot. We tried to do our best and study like in the evening and at night to get an idea of how to do that. We tried to build a flowchart to have an idea of what we could do for those patients. And then on the 18th of March, I got COVID and I had to stay at home for 1 month. And so actually I experienced COVID-19. At that time, it was, and then I will tell you how actually the symptoms I had and I felt it. But it was 1 month in which I stayed at home and I tried to help my colleagues the best I could. So we all research and trying to kind of clarify the flowcharts and internal guidelines. Well, then I went back on April the 20th, and then it was managing COVID-19 again with less patients at the beginning of May, let's say, and much more experience from my colleagues. So it was somehow easier, and we had a lot of COVID-19 wards in Turin, so it was somehow easier. So this is the most, it's a funny slide. So just switching from doctor to patient. I know the patient face looks funny, but I was trying to make people at home relax that I was fine. Even I was in a hospital, I was admitted, and I was trying to have them relax, and everything was under control. So this is a clinical case. Yeah, of course, we need no consent because it's me. I'm male, 41 years old, European ancestry. I have no relevant past medical history, not taking any medicine. I work as an ID physician in the ID hospital in Turin. Before the first case, or just the beginning of the first case, we had several meetings with a lot of colleagues in order to kind of build up the workflow and to understand how to use the helmets for CPAP and etc. So we actually were together in small rooms, in a lot of meetings, and I think that was one of the possible way I got the infection, and several of us got infection. On March 17, I started with severe back pain with like cramps in the paravertebral muscles. And on March 18 in the morning, I had asthenia, back pain, and low-grade fever. So I did the nasopharyngeal swab. It was positive, and so I stayed at home, started hydroxychloroquine, and also both a pulse oximeter. On the day after, I tested my partner, and she was also positive. So we were isolated at home together with our children. The second part is that 5 days afterwards, I started having profound asthenia. I really couldn't leave from the sofa. It was really hard to just do normal things. Fever was still there, not low-grade fever. I had tachycardia. My heart rate usually is between 60 and 70 per minute, and was 100, 125 per minute. And my blood saturation at pulse oximeter went down to 93 to 95%. So on the March 24th, still the symptoms were the same. I actually called some of my colleagues at the ER and said, what would you do if you were me? I said, since you're a doctor, just come in and we'll check you. And so, of course, that's a risk factor for all the diseases you may think about. So blood tests were okay. The lung ultrasound suggested basal pneumonia. The arterial blood gas analysis was good. So the PF pressure was about 300. So it was really, really good. And that's what actually relaxed me at that time. I also received a lung CT scan. There was this one. As you can see, there is some ground glass and consolidation in the basal fields, 3 out of 24 fields. I stayed in hospital just for 5 days, never required oxygen. And then I was stayed at home until April the 20th. So it took me almost a month to have 2 negative nasopharyngeal swabs. So I try to put down what I've learned with these. The first thing I learned is that patients do not always lie, okay? So before experiencing it, most of our patients told me that they have back pain. I thought, okay, it's because you're in bed, it's normal. There's some muscle pain. No, muscle pain is really bad. It's like cramps in the paravertebral muscle. It's really painful. And I think understanding and estimating somebody else's pain is one of the hardest things to do. And I don't know, it was a tangible proof of that. Second thing I learned is actually, we know in certain case series, SARS-CoV-2 symptoms, very common symptoms is diarrhea. And also hydroxychloroquine, lopinavir that received just for 3 days, also is associated with diarrhea. So diarrhea could be very bad. I have between 10 and 15 discharges per day. It's bad. But it's even worse if you are in an ER room with 20 patients and there is only 1 bathroom. So I think some logistics could help how patients feel in certain situations. And the third thing I also learned is that arterial blood sampling is painful. So we know that there is this kind of coupling between the pulse oximeter and arterial PO2, but it's painful. I received 4 And actually, after that, I thought before, is it really necessary? Is it gonna change my practice or my treatment or not? So if the answer is not, maybe it's not necessary to do it. So number 4, I also learned that in certain situations when somebody doesn't, even if he knows how things are going, there is a certain level of anxiety, and small gestures really warms up. So one night, a nurse that has some hands brought eggs in the hospital. She cooked the eggs and smuggled them in the red zone. So I received a fantastic fried eggs at midnight on one of the days I was admitted. So, okay, it's a small gesture, but in certain situations, it's a very nice thing. And the last thing, I actually knew this, but I experienced this, so it's kind of different. So doctors usually spend very little time talking to patients. It's true that nurses and healthcare assistants spend more time with patients. And I understood this because the patient next to me, when doctors came in and asked, how are you? He just answered fine, nothing else. But when I realized I was an ID doctor, he made like kind of 1,000 questions, like, is it normal? How long will it last? Is this symptoms okay? Is something strange? Really a lot of questions that he didn't dare to ask his doctor. So that's something a bit strange. And then the last of the things I probably learned is that there's a way, or there could be a way, that the bad thing, such as having COVID-19, could turn into something at least useful to others. And so I donated plasma because I have a high titer of IgGs against SARS-CoV-2. So I hope it will be useful for someone else. And another thing I actually experienced from the two sides of the coin is that when we have a new patient coming in with a new HIV infection, we try to tell him, after assessing psychological status, is that it's not really that important to understand when and from whom he got it. So how the context, well, who was the person that transmitted the virus? But it's not true. I think I spent many hours while I was in hospital where time is really slow, thinking, was it that meeting when I talked to this doctor and then he had COVID? Or was the second time I put the mask and I forgot to change the gloves? And also you go back and think, did I make a mistake? Because dressing and undressing, when you have a lot of patients, it can be stressful, can be something wrong. And so it's not that easy not to think about these. Actually, if you experience it, which changes a lot. And I think the common word of these all epidemics is fear. I think fear is really common in COVID-19 times. Talking to several colleagues, the greatest fear most of them had was not of getting COVID-19, was it transmitting it to family members. And so some of them isolated themselves for like 2 months in a single room in their house, or just rent a small flat not to transmit it at home. And so you work a lot of hours, you feel stressed because of your patient, and you also are isolated from your family. And that actually increases the bad times going on. This, for example, this is a serology of our 3 children, and 1 out of 3 has a positive IgG band. So she probably had COVID-19 with very few symptoms. That's even a good thing, but actually the fear of transmitting it to my children, I already transmitted it to my partner, so it's something really worrisome. The second thing is, I think several people at the beginning of epidemics fear being scaremongers. So some hospitals forbade the use of facial masks outside the visit of patients. So just like going to a hospital and meeting with our colleagues. And I think that was a mistake, because that could be, at least at the beginning, a way of spreading a virus to several healthcare workers, just not directly from patients, but among us, let's say. And the third fear thing all of us felt is the fear of being inadequate, of not doing enough for our patients. And so this is a nice editorial in JAMA that point out that sometimes not doing anything, it could be as good as doing something that is not based on evidence. I think some of the choices we made were also based on no evidence at all. And this is my personal experience. Then patients' fears are even more profound. They include fear of dying, I didn't experience. The fear of having affected someone in the family, that actually, this is something I experienced. And something I felt is, think of a family where both parents are sick. Who would take care of children? that have been probably in contact with SARS-CoV-2. And that's something that was really, really fearsome, and that just goes around and around in your mind. And isolation, so you're not able to talk to others, it increases these. I also wanted to stress the fact that technology was very good and very bad in this epidemic. It was good because when we didn't have a computer to talk from the red zone outside, we just put paper on a window and took pictures, and so everybody could just receive the same information on the other side. And we also were able to have patients video call their families. At some time, I remember a patient telling me that was 2 months he was not able to talk to anyone in his family, and I think and they actually saw each other and they cried a lot. I think it was really, really nice. So technology was fantastic at the time. It was also very bad because a lot of misinformation, of very stupid theories, a lot of, I don't know, it's the first time I received it by WhatsApp, at least 5 or 6 times. I received news like, I'm doctor and I discovered a cure for COVID-19. They don't want to tell you, but there's a cure and I discovered it. And of course, I received them, but also patients received them. And so how to manage information, even at a very singular level, it's complicated. And I think it was the very ugly side of these epidemics. This is the only other scientific slide I put in. This is a serological study that we did in all healthcare workers in our hospital, in the 4 hospitals we work in. And so out of 7,000 healthcare workers, we were able to include 5,444, and zero prevalence was almost 7%. So almost 7% of our healthcare workers had COVID-19. There's a slight difference in those that had a direct contact with patients, 7.5%, with those who have an indirect or no contact with patients, 5.2. So of course, if you're exposed to the patient, there's a slightly higher risk of that. And this is something we use to understand how the epidemic spread in our hospitals. I would like just to conclude with 2 slides, 2 acknowledgement slides. The first one is to all my colleagues. They did a fantastic job. Sometimes it was really hard in terms of working hours and stress, and I think we did our best. Probably it was not perfect, but I think we really did our best. And in the black box on the right, you see that from official data in Italy, we had more than 28,000 healthcare workers that got COVID-19, and 163 died. No, 200 died because of COVID-19. There's a website of a Federation of Doctors in which there are names of all those who died. And I think it's really touching because then you give a name. You can also imagine a face to all the patients, that all the healthcare workers that were working and doing the job, they died. And the last slide is a personal acknowledgement slide to my partner, because we share the good, bad, and COVID-19. To my children, they were really passionate. I think they helped me. At some stages, I think I was just thinking too much about COVID-19, how to do and what to do. And my 6-year-old child at one of the dinner asked me, "Daddy, what is tocilizumab?" And I think it was, I'm talking too much about it, and I need to just change my mind a little bit. And to my mother and sister that actually took care of us when we both were sick. It meant like cooking and shopping. And I think it happened for many people that got COVID-19, that they needed the help of others. And it was a fantastic gesture, and I want to thank them. And I thank you for your attention.
Good morning, good afternoon, and good evening. It's a privilege to speak to you today. I'm speaking to you, a community that's been through 30 years of a slow burning global pandemic. And I'm speaking to you after almost 200 days since WHO activated its emergency response to this acute global pandemic. COVID-19 emerged in late 2019 and has spread globally at an unprecedented scale. Over the next few days, we will reach 10 million cases and 500,000 deaths globally. The virus has impacted communities in all parts of the world. Although we see a decrease in confirmed cases in some countries, the acute response phase of this outbreak is not behind us by any measure. The evolution of the pandemic has varied by region, and while cases in Western Europe and Southeast Asia are falling, in many countries the pandemic is still developing, with peak transmission and impact yet to come. The COVID-19 crisis is presenting enormous challenges to health, social and economic systems that can only be fundamentally addressed by controlling the epidemic. But how can we achieve this while sustaining critical health services for other diseases and preserving livelihoods? We are at a critical point in this pandemic. We must focus on what we have learned about controlling transmission, reducing mortality, empowering communities, and good governance. We cannot become distracted with retrospection and finger pointing. How can we save lives, protect the vulnerable, control the situation, decrease transmission and death rates, find a vaccine and therapeutics? We need to look ahead, remain vigilant and focused on every lesson we learn day by day, as you have as a community in HIV/AIDS. However, some of the core factors that have led to this wildfire are not new to WHO. For decades, we have flagged the critical importance of health systems preparedness and readiness, the importance of resilient and dynamic public health systems, and the high likelihood of a global pandemic. What we have seen over the last 6 months was a failure of public health systems to protect and shield health systems, and which have taken the full brunt of this epidemic. Chronically underfunded public health systems have struggled to detect, investigate and isolate cases, to track, trace and quarantine contacts, and provide a comprehensive response. Transmission suppression has required a quick and strong emergency brake in the form of movement restrictions and lockdowns, which in turn have triggered socio-economic repercussions of a magnitude we all still struggle to fully fathom. The COVID-19 pandemic has put extraordinary pressure on health systems. The immediate impact is already tangible. WHO's survey and disruption of services across regions. Early results show that more than half of countries surveyed have limited or suspended outpatient services, community-based care services, and on average, approximately half of the 25 assessed health services are disrupted, partially or completely, in countries. 32% of countries reported to us at least partial disruptions in HIV services, while a first set of data released by South Africa in early June found that people living with HIV had a much higher risk of death from COVID-19. However, further research is needed to understand the full extent of the interaction between HIV and COVID-19 outcomes, the impact of co-infections, which have an impact on the course of the outbreak in any country. The fundamental stress test highlighted the consequences of the lack of focused investments in essential public health functions and capacities for health emergency and disaster risk management, and has exposed weaknesses in service delivery to quickly scale up COVID-19 treatment while maintaining essential services. And this has also occurred across the income spectrum. This is an issue that has occurred in the north as well as in the south. Lack of access to health services, now exacerbated by this outbreak, has left billions of people, including many in wealthier countries, without reliable and affordable access to essential health services. Furthermore, massive inequalities have led to deaths and loss of livelihoods being strongly driven by socio-economic status and further compounded by gender and minority status. Would all of this have happened if countries had reacted quicker, if countries had reacted with more comprehensive strategies, if countries had stronger primary health care, stronger public health systems in place? This is not a time for what ifs, because what we need to do now is go forward. The pandemic has happened, and we need to face the realities of its impact and the reality that health systems will be equally exposed again in the future unless we act now. Are we going to let this happen? We need to immediately build stronger capacity to control disease transmission by breaking chains of transmission, and we need to make the health system more capable of coping with large numbers of sick people. We need to do these two crucial things while preserving other essential health interventions and services, and we need much stronger community ownership and governance. I am sure those of you who have worked in HIV for the last 30 years are deeply aware of the importance of all of these factors. How do we want to rebuild a stronger health system, a system which has been underfunded, which is already now spending precious resources on the COVID-19 response? When COVID stops, who will pay for the recovery? How will building back be better? How will it be feasible at a time when every single sector of society is looking for resources to rebuild? Equitable access will be a key element that will allow us to come out of this stronger. We need to take a leaf out of the HIV/AIDS activist book and ensure that equitable access to future vaccines, therapeutics and all COVID-19 response products and services. WHO is excited to be part of the groundbreaking new Global initiatives such as the Supply Chain Task Force and Consortium and the ACT Accelerator, the Access to COVID Tools Accelerator, which is building and striving for equitable access to supplies, vaccines, therapeutics. What has also given me hope over the last months is the relentless pursuit of science to understand the virus, the social context of the disease, to develop vaccines and therapeutics. At a time when noise and speculation appear to be the single driver of policy, we need to go back to evidence and science. We need social science as much as biomedical science. We need to take into account the dynamics of a disease within a society and how it generates either prejudice or acceptance. We are a community, a local, a national, and a global community. How can we build alliances and develop a society that responds positively to the challenges we face? When I reflect on the experience of the HIV movement, I can't help but see that COVID and HIV are different in their scope, in their nature, and their impact, but they're comparable in so many other ways. Both have exposed the same inequities, injustices, the same denial, the same fragilities in society, the same prejudices, exclusion and stigmatization, the same weaknesses of governance, and the same inequities of access. We have to learn. At what point do we wake up and say enough? When are we going to talk about sustainable growth, sustainable development? There must be a third way. A crisis can bring out the best and the worst in us. We can choose to see this as an opportunity to learn and to grow instead of casting blame and putting our heads in the sand. This could turn out to be the greatest era of change that has ever been, or our greatest missed opportunity. Thank you.
Good afternoon. It is my pleasure to talk to you for a few minutes about anti-Black racism and COVID-19 inequities, explaining the system, exposing the setup, and exploring solutions. I do not have any conflicts of interest to declare at this time. Any discussion about racism must begin with the discussion of what actually is race. What we know is, as a popular notion of race, and an accurate notion, is that race is a classification of people based on sort of innate biological differences, or that people have emanated from sort of multiple origins of human forms. This is not true. Modern humans, that includes all of us here listening and watching today, originated in what is now known as Africa. That it is a place, modern humanity is of a single origin, and that features used to characterize people into races are a function of movement distance from their origins in Africa. The figure that you see here is from work by Dr. Sarah Tishkoff at the University of Pennsylvania. And what it is actually showing is that these circular colors, which are sort of typical groupings of people into so-called races, are actually made up of multiple ethnic groups who are not genetically homogeneous. So that these groupings are not a scientifically valid biological taxonomy of humans. It is, in fact, a social classification of humans. So we know, not just from this work, but even from decades-long work in the Human Genome Project, that race is indeed a social concept. So when we understand that race is a social concept, we can also understand how racism is a social classification system that uses this false concept of race as a biological grouping to reinforce a system of power. Racism is in fact a multidimensional organizing logic of human power relations. The figure that you see to the right is a stunning depiction of sort of 4 dimensions of racism, the system of racism, which includes structural forms, institutional forms, which are enacted through policies and practices within organizations to uphold racist standards. And these organizations can be hospitals, they can be public health systems, they can be universities. Interpersonal forms, which are racist acts that happen between people, and internalized forms. Racism, the system of racism is continuously operating and does not require conscious participation, which is why it's so important to acknowledge the structural and institutional forms because they do not necessarily depend on the actions of individuals. They are enduring forms. The system of racism also distributes social status benefits based on race category assignment. So the classification of someone as white or black is actually an assignment to a social status, with white being assigned to high social status and black as a category being assigned to lower social status. This has implications for how various uh, things in our society are distributed, including how we distribute access compared to barriers, how we distribute immunity compared to punishment, and how we distribute justice versus apathy. Those are not distributed evenly between the groups. Those are distributed based on whether you're assigned to a group as either white or black or another race social category. We also know that whiteness or high status can be assigned provisionally and it can be revoked. We've seen this in the aftermath of tragic social events like 9/11, in which white-skinned people became Arab in American society. That whiteness, that privilege of white skin was revoked, at least temporarily. We can also see how it happened in the onset of the COVID-19 pandemic and its impact in the United States, in which people who may be identified as Asian or Chinese uh, uh, may have been afforded a degree of whiteness that was revoked, and that you saw that in the ways in which there was multiple stigmatizing racist attacks and narratives against people who were assumed to be in this racial grouping of Asian. So racism is a form of structural violence precisely because it produces socially unjust conditions that predispose Black communities to disability and to death. These maps that you see are from a recent publication in the Annals of Epidemiology that are provided courtesy of a colleague of mine, Greg Millett, but it shows the overlay of health and social disparities that are distributed, if you can see in the colored portions of this map, in particular parts of the United States that have higher proportions of Blacks in those communities. So that includes poverty, unemployment, and lack of health insurance. Those are social disparities and how those are distributed. You see the same thing for health. One is syphilis, the middle green color is diabetes, and the blue one at the bottom is heart disease. So these are things that are already happening before COVID-19 has even had an impact on communities in the United States. So this system has already set people up to have disproportionate, inequitable impact from viral zoonotic pandemics. What you see now is a similar map, but you see the same pattern. This is for COVID-19 diagnoses, that these are disproportionately impacting Black communities in that same geographical pattern. And for COVID-19 deaths, there are fewer of those, but if you look down into the darker orange parts of the map, which I think is South Georgia, North Florida, and the Louisiana Panhandle, you see disproportionate rates of COVID-19 deaths in the same areas in which we saw disproportionate rates of poverty, uninsurance, and unemployment, and health disparities that will make it more likely for people to have severe complications to COVID-19 disease. And this slide is showing the disproportionate rates of cases and deaths among Black people in the United States. And what you can see to the left is showing deaths. And in almost every state in the United States, the proportion of deaths to COVID-19 are not proportionate to the percentage of Blacks who live in those states. If you look to the right at cases, you see the same pattern. What the orange and the dark orange is showing you are the differences between the proportion of Black people who live in that state and how it compares to the proportion of cases or deaths in that state. So the more darker or deep orange you find, that is showing that those are more disparities within those jurisdictions. So these are the same patterns. It doesn't matter the disease that it is in place because racism operates as a structural system. And so the results are the same no matter what. But there are things that can be done, and I'll just describe those. First, we have to be clear that we're fighting on two fronts, and we have to be fighting each front simultaneously. Ending racism cannot be triaged to a post-COVID-19 priority. We must reverse inequitable structural public health and social policies that funnels vulnerability to Black communities. This includes combating structural racism and systems of white supremacy, which will require active and sustained measures, not one-time, not ad hoc measures, but a sustained and active effort. It includes, or should include, advocacy at the local, state, and federal levels, as well as through professional organizations. We, as a science medical community, must support those risking their lives to fight on both of these front lines. The front line of COVID-19 pandemic, which is taking lives, and also the front line to end anti-Black racism, which is also taking lives, which is accelerating death among the COVID pandemic, and has been going on for a very long time. There are people risking their lives on both these front lines. We must support them both and find ways to do so. We must also mitigate the material conditions that increase vulnerability to COVID-19 and death. This includes improving access to technology, healthcare insurance, secure housing, and opportunities for income. We must also immediately incorporate anti-racism and structural competency into healthcare professional education, both at the curriculum level and the evaluation level of the students and of the people who are teaching these students. This includes nurses, physicians, physician assistants, public health professionals, social workers, you name it. And it's not just classroom work, but it should also include residencies, fellowships, and continuing education for those who are licensed or also working in the field. And to end, COVID-19 and anti-Black racism both require rapid multi-level responses aimed at eradicating and preventing their resurgence. We need less theorizing, less apologizing, more mobilizing, and more action. These are two emergencies that are happening right now, and both must be ended as soon as possible. And finally, I'll say there's been a lot of talk about reforming systems, various systems. Should be clear, racism is not a system that can be reformed. Racism must be dismantled. This sculpture you see here is from an artist in Toronto, Canada, France, Brent Harris, and it is called The Awakening. It is sort of an opening up of, this is a gay Black man on this stool, but opening up to possibilities of a new world. And I think the world is also having an awakening. It is what we're seeing right now. And the awakening of the moral conscience of the world is an opportunity for us to restructure society to protect all human life and the ecosystems that sustain human life against the pandemic threats of racism and COVID-19. Both these are very urgent, and it is important that we tackle them both. Thank you.
The mantra, leave nobody behind, has been said many times in relation to the global response to COVID-19. But in the world today, migrants, refugees, and displaced people are left behind. They remain amongst the most exposed and the least protected. COVID-19 has amplified and deepened existing structural inequalities and neglect in our health systems and society. For years, states have failed to invest in universal healthcare for all, actively excluding migrants and refugees from care. In the eyes of many in power, protecting the health and well-being of migrants is not a priority, and COVID-19 has just magnified this. MSF is working in 30 countries with internally displaced people, refugees, asylum seekers, and migrant workers to provide access to care and targeted COVID-19 responses, ranging from health promotion and setting up isolation facilities in camps in Syria and Bangladesh, to running COVID-19 ICU units that accept all patients, including migrants and refugees in Brazil and Yemen. Our response has been diverse because the settings and the needs of migrants are diverse, but the underlying exclusion is not that diverse. The health of migrants is compromised due to pre-existing risks, such as poor living conditions, lack of access to healthcare, and their legal status, but also because COVID-19 prevention measures, such as lockdowns and border closures, can amplify these vulnerabilities. Public health measures should not be used to discriminate and further stigmatize migrants. Migrants and refugees should be considered and included in all national response plans. We have seen positive examples of this. For example, in Portugal, migrants and undocumented people were provided access to healthcare as part of the national COVID response. But this is rare. Other countries have disproportionately applied measures against migrants. In Greece, more than 17,000 people remain living in slum-like conditions made for 3,000 people on the island of Lesbos. As Greece opens up for tourism, asylum seekers remain in lockdown in conditions that are prone to disease spread. Governments should decongest such facilities and should especially move out those most at risk from COVID-19 to safe accommodation where they can apply prevention measures. In overcrowded camps and dense urban settings, much of the standard COVID advice is simply impossible. Physical distancing measures are not feasible where people live side by side in small shelters, or basic services such as water or food are provided communally. For example, in Bangladesh, which is home to 1 million Rohingya refugees, MSF has established more than 260 COVID isolation beds. But this is just a fraction of the required capacity necessary for the widespread outbreak within the Rohingya community. Surveillance, testing, and contact tracing need to be increased massively here and in similar camp settings. But this has got to be done in a way that respects the dignity of people, and that means engaging with the community and understanding their needs. MSF has implemented several simple measures to reach communities even during lockdown. Medical hotlines, digital health promotion, and home visits are all strategies we have applied to ensure continued access to care. We are also concerned about migrants living outside of camps. In the US and Lebanon, MSF has started dedicated activities to reach migrant workers. In Florida, we have started a project to increase health promotion, testing, and providing virtual medical consultations to farm workers laboring in the midst of the pandemic. In Lebanon, MSF has launched an emergency helpline for migrant domestic workers. In the first 3 months of operations, we received over 400 calls to this hotline, and a quarter of the people calling are using the service for mental health response. Many of the people have been victims to some sort of physical or sexual abuse. These are just a few examples, but it demonstrates without the inclusion of all people, especially those that are most marginalized, there'll never truly be a global and effective response to this pandemic. Governments must not use COVID-19 as an excuse to enforce further restrictive migration control policies and evade their international obligations towards refugees and asylum seekers. We understand the serious challenges presented, but no public health objective can justify sending people back to life-threatening situations. And we know that from our extensive medical humanitarian experience, that when a person seeking refugee protection is refused, it puts them further at risk. In the United States, the government declared its borders are now closed and asylum seekers crossing from Mexico and all asylum proceedings are put on hold due to COVID-19. In recent months, we have seen in the central Mediterranean that European states such as Italy and Malta have closed their ports, citing the risk of COVID-19, and used passenger ferries to quarantine people rescued at sea. Boats are logically not the best place to quarantine rescued migrants upon arrival. Rather, these closures are a continuation of harsh policies that compromise the health and the well-being of migrants prior to the COVID crisis. So, how can we ensure that migrants and refugees are not left behind? Well, it's simple. Migrants must be at the center of national and global response plans to COVID-19, as well as post-COVID recovery strategies, and their access to healthcare must be ensured. And COVID-19 cannot be used as an excuse to enforce deadly migration control policies. Thank you.
Hello, everyone. My name is wanghwat. I am the Executive Director of the Center for Supporting Community Development Initiative, SCDI in Vietnam. I also represent civil society in USC's 2030 Steering Committee. So in my 7 minutes, let me share with you some of my observations and experience in community response to COVID-19. So as we speak today, there are more than 1 million people in the world have been infected with COVID-19. That's a lot of people, and we are all worried. But when you look deeper at the statistic, you will see that among those more than 1 million people who have been infected, majority of them are not have not had symptoms. That means they don't necessarily need medical care. And among the people who have symptoms, there's smaller proportion who are in critical condition. So that means if we don't want to have more people being infected with COVID-19, we need to make sure that the COVID-19 response are well implemented at the community level, so that 99% of the population are protected, are prevented from infection. And the people who don't have a symptom of COVID-19 can be cared at the community to reduce the burden for medical facilities. Community can play a very critical role and need to play a very critical role in COVID-19 response. There are some direct health response to COVID-19 at community level. We need to provide information on COVID-19, how it is transmitted, how to prevent it, what to do when people have symptoms, what to do when people are suspected of having COVID-19. We need to work on behavioral intervention, social distancing, hand washing, mask wearing. We need to work on contact tracing, make sure that people who are infected with COVID-19 know who they are contacted with, and that the people who come close to contact with the people with COVID-19 are taken care of, so that they will not develop, they will not transmit to others in case that they are infected. Community are the first responder. When somebody suspect that they may have COVID, somebody who have symptoms, somebody who have a question, somebody need care. We provide care for people in quarantine. We provide them food and masks. We monitor and manage the symptoms of the people who are not in critical condition or who don't have a symptom. And as COVID-19 happened, people working in health facility are under a lot of pressure in response to COVID-19, in increase the infection control or screening of the people for the COVID-19 infection. So some of the health services, some other health services are under the challenge because of the shortage of staff or the equipment, some such as the emergency services or sexual reproductive health, or the care for people with tuberculosis, or the prevention of malaria, since, for example, of social distancing and travel restriction. We could also see the interruption of care and treatment for people with chronic condition for similar reason. Non-communicable disease and HIV because of travel restriction, because of social distancing, because of the burden for healthcare setting. In addition to the health consequences, COVID-19 also bring about a lot of non-health consequences, such as economic consequences, social or psychological and other consequences. And the people who suffer the most are the most vulnerable and marginalized population. People can lose their income and go into hunger, or they cannot afford to pay their rent and they are kicked out of their house to become homeless. There's an interruption of education as school closed, but since people lost their job, people lost their home, then they have to move somewhere else, and the children will suffer from interruption of education. They may never go back to school. And then there's a lot of distress, a lot of depression because of the lost their income, because of poverty, because of the risk of being homeless, because worry about infection of their loved one. And there's a lot of report about increased domestic violence for many, many reasons. And one of the reasons is travel restriction and social distancing, and particularly in the poor household where they have a very limited space. And when everybody's home for a long time, it becomes a very difficult situation. So at community level, we respond to all those challenges and other challenges through education, advocacy and mobilization, working with different stakeholders, including community, policymaker, and everyone, in order to build the foundation for COVID-19 response and to respond, to contribute to respond, reduce infection and care for people who need it, so that nobody's left behind, whether they are children, the orphan children, the elderly, or the homeless people, the people who live in poverty or severely stigmatized socially. So thank you very much.
Thank you to all the speakers for a riveting session. Today, we heard a poignant keynote speech from an HIV and ID doctor, Dr. Andrew Calcagno, on the front lines during the brunt of Italy's epidemic, who contracted and recovered from COVID-19. We also heard about the emergency response to COVID-19 at the WHO from Dr. Michael Ryan and responses to similar pandemics. We also heard about the disproportionate impact that COVID-19 is having on communities of color here in the United States, and heard a plea that COVID-19 serves as a sentinel event to address systemic racism and structural inequalities. We heard about the terrible impact that COVID-19 is having on displacing individuals and on migration from Médecins Sans Frontières from Ms. Musa. And finally, in a hopeful note, we heard about the community health response in Vietnam from Dr. Quat to end this session with optimism. Thank you again for attending our session, and I'd like to invite participants to attend the following session, Country Policies and Practices, which will be streamed on Saturday, the 11th of July at 9 a.m. CEST. Thank you again.